Dear ladies and gentlemen, it's my great pleasure to give this talk regarding evaluated LV filling pressure in heart failure patients on behalf of Chinese Society of Cardiology. LV filling pressure is the pressure that fills the LV in diastole and determines stroke volume. An elevation of LV filling pressure is the major cause of congestion in heart failure patients, and it precedes the insurgence of clinical symptoms and signs. So therefore, assessment of diastolic function with filling pressure would help in diagnosing heart failure, determining prognosis, and guiding treatment. Cardiac cath is an invasive and direct assessment of LV filling pressure by using left heart cath or right heart cath LV filling pressures, including atrial contraction measure pressure, mean LV diastolic pressure, and LV end diastolic pressure known as LV-EDP, and LAP approximately equals to PCWP can be measured directly. Implantable hemodynamic monitoring sensor is another way of invasive assessment. The sensors could be implanted in different parts of the heart as LA, RA, RV, and PA. CardioMEMS, I think it's very well known among all those sensors, for it's implanted in pulmonary artery for PA pressure, and known for its compatibility with pacemaker CRTD and efficacy in preventing heart failure hospitalization. Therefore, it's recommended as Class 2B indication in ESC heart failure guidelines. Natriuretic peptides, known as BNP and anti-proBNP, showed a good correlation with LV filling pressure in early hemodynamic validation study as shown in here. Echocardiography is the first line and most important imaging tool for assessing diastolic function and LV filling pressure, in which the major parameters include peak TR velocity, E over E prime, LA volume index, and LA strength. The dilatation of LA is a chronic accumulative effect of elevated LV filling pressure, which is an independent predictor for mortality, heart failure, AFib, and ischemic stroke in patients with cardiovascular risk factors. However, it could be affected by inadequate image quality, atrial fib, bradycardia, and mitral valve disease. Transmitral inflow pattern consists of E velocity, A velocity, EA ratio, and deceleration time of E wave, which shows high visibility and reproducibility, and it's also predictive for clinical outcome. However, it could be affected by age, heart rate, and preloading condition. Although with a similar limitation compared with the transmitral inflow, the mitral annular velocity, E prime, shows its great advantage as it's less dependence on preloading condition. Pulmonary vein flow consists of systolic flow, diastolic flow, and reversed atrial flow. All those three components are found to be correlated with the increased LV filling pressure as LAP, PCWP, and LV-EDP. By using this formula, pulmonary arterial systolic pressure could be assessed by tricuspid regurgitation velocity, which shows a good correlation with mean LA pressure. And pulmonary hypertension is regarded as a prognostic indicator in heart failure patients. However, it's not applicable in patients with trivial TR, or on the other side, in severe TR, but RV impaired systolic function. LA strains, in particular LA reservoir strain, are found to be new markers of elevated LV filling pressure in this invasive validation study. The LA strains compared with the invasively obtained parameters for LV filling pressure. And it found that the accuracy for assessing LV filling pressure was higher in patients with an ejection fraction of less than 50%. And this figure vividly demonstrates the grading of diastolic function from normal to impaired relaxation pattern, pseudonormal to restrictive filling, and also as well as a gradual evaluation in LV filling pressure as reflected by the changes in the mitral Doppler velocity, pulmonary ring velocity, and tissue Doppler imaging velocity. Therefore, in 2022, European Association of Cardiovascular Imaging published an expert consensus, which included a flow chart of LV filling pressure evaluation by echo, starting with the measurement of transmitral EA ratio, whether it's less than 0.8 or more than 2, followed by E over E prime, TR velocity, and LA volume index, and finally confirmed LA reservoir strain. And this could be used in both REF and PEF patients. However, it's not recommended routine measurement in patients with no suspicions of heart failure or other heart diseases to prevent too many false positive diagnoses of elevated LV filling pressure. The measurement of preclinical or subclinical congestion could reflect the underlying increased LV filling pressure. So long ultrasound B lines can be read as the degree of extravascular non-water. The more numbered B lines, the more severe pulmonary congestion. Non-fluid monitoring system known as RETS uses electromagnetic wave to measure or to read the non-fluid content in percentage to see whether it exceeds the normal range of 20 to 35%. Now, the question is whether continuous monitoring of LV filling pressure useful or not. It has been previously observed that an elevation in LV filling pressure occurs earlier than heart failure hospitalization, and improvement in LV filling pressure found to be associated with symptom relief and reduction in heart failure rehospitalization. So, could an earlier identification followed by an earlier intervention to lower LV filling pressure reduce adverse events in heart failure patients? This study recruited 26 patients with PLH and right-hearted heart failure who were implanted with a CardioMEMS sensor and data transmitted weekly. We could appreciate there's a rise in PA pressure before heart failure hospitalization and a drop in PAP after the initiation of IV diuretics and titration of target treatment after admission. Our own study recruited over 100 patients, which investigated the fluid status at discharge of the patient and with the midterm prognosis known as the all-cause mortality or rehospitalization for heart failure. We could appreciate in here that the non-ultrasound B line could further stratify the patient into different groups and identify the group with the best survival was those with dry status and B line negative. In REDS heart failure study, patients self-monitored volume status and uploaded data daily at home, while physicians read pulmonary edema remotely and adjusted diuretic doses according to the REDS reading and to try to keep it within the normal range of 20 to 35%. And the results shows that the readmission rate decreased significantly during the risk-guided management period compared with the pre and post-risk periods. So ladies and gentlemen, let's summarize. LV feeding pressure is very important assessing heart failure patients. Based on LV feeding pressure increased or not to grade diastolic dysfunction is very comprehensive. The methods of assessment include cardiac catheterization as the golden standard. BNP and echocardiography are most commonly used. In the meantime, implantable and wearable monitoring systems are very promising, and it's highly expected that continuous monitoring of LV feeding pressure can predict events in advance and guide immediate treatment in heart failure patients. And I would like to thank you for your attention. Thank you.